Okay. Good evening, my colleagues, my friends. كل عام وأنتم بخير. This is webinar بعد الفطار. Actually, it's an honor for me to have my friends, Professor Ziad Ghazal, a professor of cardiology, Lebanon, from Lebanon, and from Emory University Hospital, the chief medical officer and founding director of the Heart Vascular Institutes. Ziad is one of the international figures. I met Ziad in 1990. He was in Emory University Hospital. We worked together. Ziad has an international respect all over the world, and then he came back to Lebanon to be the vice dean, and he's creating a great hospital and institute for regarding the Heart and Vascular Institute now. Also, my friend Professor Hadi Abu Hantash is a friend also to the Egyptian, like Ziad Ghazal, once to the course directors also for the Cardio Alex CVRF Foundations. Dr. Hadi Abu Hantash had his MS from Alexandria University Hospital, and was an honor to meet him when I was was resident in the university. And he's now in intervention cardiology in Jordan. He learned the United States, and all of us learned the United States. That's why we choose to be an expert learned in United States. 3 figures from United States. My name is Mohammed Sobhi, Professor of Cardiology at Alexandria University, and CEO of the CVRF Foundation Cardiology. And thanks to abates, in particular Dr. Hassan Hamouda, the CEO of abates, who is sponsoring this webinar for the Expert Lessons Learning series. When we talk together, we choose is it to be an ordinary webinar or not. So Ziad, Hadi, and me choose 3 cases for you, 3 interesting cases. But because of the COVID pandemics, we will not leave it all the COVIDs. So we choose that Ziad will give you a snapshot about the ACC position statement of the COVID in the last 2 weeks. It started by Sky, and then the European Society of Cardiology, finally the ACC and Sky together. And Ziad is going to present you a few slides regarding this COVID statement. Let's start with Ziad.
Thank you very much for the introduction, my dear friend, Dr. Sobhi, the friend to all interventional cardiologists in the region, actually. So you have all seen plenty of information regarding COVID during the time when COVID was really quite hot. Now that things have started to relax a little bit, we are going to discuss the safe reintroduction of cardiovascular services during the COVID-19 pandemic. And we're going to give some guidance from the North American Society leadership. This was released in JAC just a few days ago, so this is a fresh statement. And it's important to sort of remember where we are with all of this as we start to reintroduce our services. First of all, physical distancing is going to stay with us for a very, very long time. So in the hospital and outside the hospital, specifically in the hospital, this is going to stay probably 2021, a good part of 2021. And the visitors policy, I'm sure all of you in your hospitals, you have a visitor policy which limits visits, is going to also stay with us for a very long time, because it's a matter of working with the waves and the surges, and we have to be prepared. Now, COVID screening, and I want to ask both Hadi and Muhammad regarding COVID screening. Here, the ACC says to encourage routine screening of all patients prior to any cardiovascular procedure. Do you do such things in your hospital, Muhammad or Hadi, to screen all patients going for cardiovascular procedures, COVID-19 screening?
I personally, I've been doing that, Ziad, but I would not say that it's been done systematically around me. So.
But how about people going? Let me tell you, at the American University of Beirut, we started about 3 weeks ago at the request of the anesthesiologists and the surgeons to do such screenings for all patients going for surgeries, especially those requiring general anesthesia because intubation is result producing. But we have not been doing it routinely for cardiovascular procedures. And Muhammad, do you
No.
No.
Till now, we don't have the test in the hospitals. It's not in the private. So we're just screening with the patients if there is fever or chest infection, or we do a CBC, and in suspicious, we do CT. Otherwise, we don't do any tests till now because already in the belonging to the Ministry of Health, it's a centralized. So I think after the pandemic will be finished to be available in all private sectors. Even in our university, we don't have this test till now. I don't know what's going in Jordan, but till now, restricted because they need to have centralization to collect the numbers. So that's why we're just speaking on the clinical and some of the lab.
Right. We have the PCR nasopharyngeal testing, and we on all patients going to the operating rooms, as I said, but not for cardiovascular procedures. In terms of emergent cases such as STEMI, STEMI patients and urgent surgery, we need to remember that aerosol generating medical procedure will likely to continue to require the highest level of PPE. So what does that mean? And this is for the foreseeable future and for really a longer period of time. So anytime we have a STEMI today, even the COVID-19 census is on the low side and the concern maybe is low, we have to be prepared to protect the healthcare workers, protect ourselves when we have emergent cases in any condition of STEMI. Why? That means, what's the difference? So you have to do contact and droplet isolation. So you have the gown, the gloves, and the mask and the shield, the eye shield. But the mask here should be N95 mask, not the regular face mask, because the N95 mask has a filtration of over 95%, and it's important for aerosolized procedure. Now, of course, the cath lab, when we do a STEMI, it's not an aerosol generating procedure, but in case there is an arrest in the cath lab, which may happen in people with STEMI, then this becomes a procedure where we have to be fully protected. Now, the statement here goes into response levels, meaning level 0, meaning that's a good level where regular services can be conducted, can be offered. And this is where we have ongoing COVID-19 testing and surveillance and monitoring of PPE availability. Level 1 is where we reintroduce most of the services, and level 2, when we reintroduce some of the services, and I'll go into that in a little bit. So it is expected that different regions will be at different level of response as the pandemic either escalates or abates. So Jordan may be different than Lebanon, or different areas than Lebanon may be different. The decision regarding transitioning between response levels requires a close collaboration with public health officials and health systems. So we cannot be working in silos as a hospital. We have to be very attentive to what the local health authorities are producing in terms of information and recommendations in general in the country. And this is a dynamic and continuously evolving mechanism as new information becomes available. It's almost a daily census of the COVID-19 in the country and in each region of the country, which will affect how the hospitals will react to heighten the alert or lower the alert. So if we go to specific situations, let's say we have STEMI, they consider it the same for all levels, meaning that if the COVID-19 status is unavailable at the time of STEMI, so in other words, you have a patient coming with STEMI, but you know if the patient has COVID-19 or not because the status is not available, you use PPE, and you are already in sync with what the regional health authority has dictated. And today, as we are recovering from the first wave of the pandemic, primary PCR is offered for most patients, while selective pharmacoinvasive therapy, as per regional practice. You know, during the bad times of the pandemic in Europe, when many centers were receiving a lot of sick patients, STEMIs were not given a high priority except for very sick patients, and some of them were given lytic therapies. But right now, that's not really required. We go for primary PCI. And if there is moderate to high probability or COVID positive, so if you have COVID, if the patient came to your hospital diagnosed with COVID and suffers an MI, then the first thing you need to do is consider alternative investigation rather than immediately going to the cath lab. Just start with transthoracic echo or CCT prior to cath lab activation or pharmacoinvasive therapy. Now, in terms of ACS or non-STEMI, if you have high risk non-STEMI and if you are level 2, meaning you are at a stage where there is a moderate census of COVID in your area, so you want to be careful. If you have a high risk non-STEMI, you still have to do invasive strategy. That is if you have refractory symptoms, hemodynamic instability, significant LV dysfunction, so on and so forth, GRACE score more than 140. If you have medium risk non-STEMI, you do selective invasive strategy. So you don't have to go invasive all at once. You could do medical therapy and then decide to do invasive therapy if the patient is not stable. And then if you have a low risk non-STEMI and unstable angina, you do medical therapy and you defer your cath to later. However, if we move to the center in green, level 1, where we are reintroducing most of the services, and that's also dictated by the status of COVID in your area, then here the main difference is that for medium risk, rather than doing selective invasive, we're doing invasive strategy on all medium risk. And on the low risk, rather than deferring all the cath for all low risk, then here we're doing selective invasive strategy. And if you are at level 0, where regular services are offered, then you do routine services for all cases. There is one last slide, which I don't need really to go into, which really goes with the same idea. One example is TAVR. If you are in level 2, which means you're reintroducing some of the services, then you do TAVR for inpatients and outpatients only if they have severe symptomatic aortic stenosis. But if you are reintroducing most of the services, then you do most patients that are accepted by the heart team, and the stable cases may still be deferred. And level 0 is where you do offer or routine service for all cases. So that's really the gist of it. It's just a matter of using common sense as we approach what response level we are in the region where we live in. But I think the key message here from all of this is to continue to use the proper precautionary and safety measures that we have learned with COVID-19, and we have to use this for a very, very long period of time without relaxing those policies. Thank you very much.
Thank you, Ziad. Regarding, it's wonderful to see these last slides from, see, can I add to this? Actually, in Egypt, we didn't do a pharmacoinvasive, we didn't change the guideline even after SKY, because fortunately we don't have a lot of cases there. So we still have a primary PCI. I think Lebanon the same, and
yes.
Jordan. Last week I have a meeting and I have collected data from Jordan, Lebanon, Saudi Arabia, Emirates, and Egypt. Actually, all these parts of the Middle East are doing the same primary PCI, and then I may have this talk with Pascal. Regarding adding to the STEMI, we learned a lot about the PPE. We learned a lot about double gloves, double glove. It's called, everything is double. I mean, if you have a suspecting, make it double for the gloves, double for the masks, double for everything. The second that the introduction of the endotracheal or something like indication of techniques of ventilation of the patients should be done outside the cath lab in case of either STEMI or non-STEMI. Number 3, if you have a proper negative cath lab, it's good. Fortunately, I learned this since a long time, but I couldn't imagine that this is important nowadays, the negative cath lab.
Negative pressure.
Negative pressure cath lab. Negative pressure cath lab, which means that there is continuous flow with air condition, something like it's negative pressure, not coming from outside. The third, we do the culprit like before, only we didn't do, except that in some situation that we are so busy, but in our country, we still do the culprit. This is adding for the high risk patient, non-STEMI, we are doing the same, but this is, we have time to do the test or the antibodies. We don't have the test immediately. We ask for this antibody for the elective, but not for the STEMI, because you don't have for the STEMI. Second, do you have your advice yet and to have a COVID cath lab, a non-COVID cath lab in the future, or you should have only, if you have only one cath lab to do?
I really don't think so. It's hard to, because cath labs usually exist. Could be maybe 2 in an institution or 3. So it's hard to dedicate one to COVID. For example, operating rooms, we have 10, but we have created a building for COVID, a building, which we have a standalone building, 5 stories for COVID. So we put an operating room on the 5th floor. We actually constructed an operating room because there are so many operating rooms in the hospital, we can spare one here. But for the cath lab, it's difficult. Same thing when you do CTs, for example, when you want to take, it's hard to do one. Now we have dedicated one. In fact, we've used it only twice because we have a low volume of COVID. But if you don't have enough CT machines, you just have to disinfect the room after you do your COVID patient. That's all it takes, and it's safe.
Okay, Hadi, a comment?
Oh, yeah, I think I agree with you. It's not an easy thing to dedicate one cath lab in every institution for COVID patients, especially considering the number of cases we have. We hardly have 500 plus here in Jordan, so you can imagine it's not an easy task. And I wanted also to clarify to Ziad, that the ones I do systematically, the COVID test, and I don't have to wait for it like an STEMI patient to wait for the results, are the ACS patients yet. I don't do it just systematically to everybody, but the ACS patients, because sometimes, especially in STEMI, they can deceive us, sometimes they have a STEMI secondary to fulminant myocarditis and stuff like that. So.
There is a question here, Ziad and Hadi, from, it's not a question, the comment from Wahab Emirates. All cases admitted to the hospital, routinely PCR swab was collected. But actually for the PCR, it doesn't take a few minutes. For STEMI, it's difficult to wait for the PCR. So this PCR swab can be for the non-STEMI, which is not high risk STEMI, not very high risk STEMI.
So as you know, there are different tests that are coming out, either blood or PCR, and there are quick PCRs that are coming out. And if already we have 2 that we're testing at the American University of Beirut, which will give you a very quick turnaround time of a few minutes. We just have to be careful because the validity of some of the tests is not as good as others. Many companies are coming out with this type of tests, but it's important to know which ones you're choosing. So if you have one that takes 3 hours to do, of course you cannot do it, but if you have one that's 10 minutes, you could use it in a STEMI.
Yes, okay.
I agree with Ziad, Mohammed, but I think like what Ziad showed in the slide of recommendations, I mean, STEMI patients, we have to take them to the cath lab quick. You take the swab, you take all the precautionary measures, the PPE, etc. I like what you said, double everything, and you wait for the results. I mean, you don't have to wait for the results to take them to the cath lab.
So the for conclusion of this talk, if you are coming back within weeks to your usual daily activities, I think you have to do STEMI with the primary PCI, do proper protection, and do the best for the patients, and do investigation, and then waiting for the investigation. But you should clean your cath lab and should have interval between suspected cases or patient under investigations, or a PUI for the next patients. Now, thank you, Ziad, for this wonderful introduction. Now we have Dr. Hadi Abu Hantash is going to introduce us two interesting cases. He has two interesting cases in 20 minutes.
I'll try my best to do it very quickly. Mohammed, thank you for sharing the time and Ziad with me, and thanks to Abu for the invitation, and thanks for the audience to stay up with us. Let me put this on the full screen. You can see it well, Mohammed?
Yes, yes.
Okay. My first case, I hope it will be short. It's a post-CABG ACS patient. And I wanted to focus on the role of CTA and the dedicated radial approach. This is from Washington, D.C. here. The patient's story is 65-year-old, cigar smoker, impaired fasting glucose, hypertensive and hyperlipidemic. He had CABG back in 2007, where he received LEMA to the LAD. And it's important for us to know that he had endarterectomy at the time, which tells you that the distal runoff of the LAD was not perfect. And he had two saphenous grafts at that time, one to the OM and diagonal sequential, and one to the right. In 2018, he came to my office with worsening stable angina. He lives in Cyprus, between Cyprus and Amman. Did the treadmill for him, it was positive with ischemic changes. He refused to have any invasive procedure, so I elected to do a CT coronary just to look at the grafts and the distal runoff. This is a quick look at the CT angiogram. This is the total occluded LAD here, heavily calcified. Distal left main with a significant disease, you can appreciate it here. And the focal stenosis in the LAD here, LAD runoff. It's very focal, high grade, couple of calcified spots here with some plaques and irregularity in the distal runoff, probably at the site of the atherectomy. This is the circ, heavily calcified all along the vessel, high-grade stenosis in the proximal to mid area here. It's very focal. And this is the right coronary artery with total occlusions with heavily calcified vessel. The grafts at that time, this is the LEMA, not the saphenous, of course. This is the LEMA graft, beautiful open graft with a runoff. And here you can appreciate the focal stenosis I showed to you in the previous images. Very focal here, you can see it, high grade. And this is a beautiful sequential graft going to the diagonal and then coming to the obtuse margin. Beautiful graft for a 13-year-old surgery. And this is the right coronary graft, relatively small, but the distal runoff to the PDA is decent. At that time, this is my actually interpretation. I usually look at the CTs myself and read them with my report. I recommended conventional coronary angiogram with a planned PCI of the LAD runoff after the LEMA. That's what I recommended for that focal stenosis, because I didn't find nothing there to explain his worsening angina. He turned it down, went on okay, until just a couple of weeks ago during the COVID-19 curfew at midnight. He called the ambulance 911. We call it a Difa al-Madani in Amman. They came in, picked him up, took him to the hospital. He was admitted with a diagnosis of non-ST elevation myocardial infarction. Labs were not remarkable except for a troponin leak, which was mild. Something which adds to the challenge that he had prostatitis, cystitis, and intermittent hematuria in the past couple of weeks before admission. This is an initial EKG. ST changes are more or less generalized, but they are more pronounced here in the lateral leads. So it's very obvious to you. So I am a radial approach man, even in STEMI or non-STEMI patients. So because of the LEMA, I decided to go from the left radial artery. So how do you do it from the left radial artery? It's up to you. I mean, you can either have the left forearm supported by pillars, and you approach the radial here and get your sheath in, but you still go and stay on the right side of the patient, with the arm sitting, forearm of the patient on his tummy, on his abdomen. Some people like it, and I'm not really sure I like it much. It's not that convenient for the patient, sometimes not convenient for the operator, especially with this LEMA patient I have. I was worried about the engagement issue. This is the one which I like personally, that, you know, the patient is lying here, you extend the arm all the way out, you access the radial, you flip the screen in front of you, and you just go on from the side, from the left side. I personally like this one.
Can I ask, Muhammad, Muhammad, which side do you stand when you do a lima? From the left side, or if you're doing a left radial, you like to stand on the left side of the patient or the right side?
Me, I'm going to left side.
Yeah.
Even if I do left femoral artery, I go left side. And
but you stay on the left side. Femoral, you're going to come back to the right side of the patient after
no,
you
I start to puncture on the left and then go to the right. But
and
when
how
I go
about
left radial, I will stay with left radial. Like doing
you stay left, like Hadi is doing.
Yes,
okay.
Yes.
And you know, Ziad, something important, that there are a lot of people who are for this left radial to make it easier for the operator to stay on the right side of the patient, like what you said. They are actually advocating doing the distal radial approach, which is not a bad idea. That's not.
But it's only 2 centimeters from the radial.
Anyway. Just because of the way the patient
the way the arm is, one is anterior, one is posterior, correct.
Yeah, it will make it easier for the patient and the operator. So I started with the native right. You can appreciate the total occlusion, long total occlusion, and heavy calcification. And this is one of the most beautiful sequential graphs I've seen in my life, I guess. It's a 13-year-old. Look, it's a beautiful one. Take you through it. This is the OM here, mild disease at the hookup. It's hooked up to the diagonal. I'll show it to you here. The diagonal is over here, and retrogradely fills up the LAD. Beautiful graph. And this is the native left. That's with an abates left. I approached it. There's this stenosis in the distal left main. And to my surprise, I found this. Remember in the CT, which I did in 2018, there was a tight stenosis here. But this is a ruptured plaque with ectasia, and probably there's a defect there, interluminal defect, which is probably a large thrombus. And here you cannot see a good flow at the end, which is like almost total occlusion, which is unusual. You know, a lot of people would say that, you know, for grafted vessels, usually this doesn't happen. But so to me, obviously, the culprit most likely is this mid-circ. And we also have from 2018, we know that the distal to the Lima LAD caused them trouble. So what did I do? Oh, so this is the graft to the right, smaller graft with distal PDA open. Okay? So, and this is the Lima. Beautiful. With the Lima catheter, you can go relatively easily from the left side. And you can appreciate the focal lesion I showed you multiple times. It's over here too. And there is some disease here. I think that's the site of the endarterectomy, Ziad and Muhammad, which is the surgeon there.
Okay. Where is it now?
So what did I do? At that time, I did not want to continue because the patient was admitted after midnight. I thought that the circ lesion being the culprit has a big clot burden. So I put him in the CCU on low molecular weight heparin, thiopheban. He was loaded with ticagrelor, and he was already on aspirin. So,
Eddie, stop. Why do you are insisting in such case at night, and you have a difficulty in the cath lab to postpone because you are insisting on radial? Why not shift it into femoral approach to be easy for you to?
You mean the time after? Yeah. Well, I didn't show the next day. So what I did the first day is from the left radial, Muhammad.
Okay.
So now the second day, I overnight with thiopheban, low molecular weight heparin, DAPT. So I brought him back. Now the problem, I had an issue in the cath lab in that institution. They could not flip the monitor for me to stay on the left side. Something happened to the table. The patient requested for me that if you don't do radial, please don't do the procedure. He wanted it all radial. So I said, okay, fine, we'll do it from the right radial. So this is the right radial approach, appreciating the distal left main. After giving the thiopheban, the clot seems to be a bit less. I'm not sure if you both agree with me. It's a bit less, it's there. And then I started seeing the distal flow here, which seems to be competitive. What do you think, Ziad and Mohammed? It's not really your real, it's like a competitive flow there. And that made me stop and think. I mean, like, is there maybe the graft, the sequential was ending there or not? So I wasn't sure about that. So I said, okay, well, let me put a wire in it. So I put a wire and look at my wire, actually look at where it's going. And that made me even more suspicious that this might have been the distal arm of the sequential graft hooked up there, Ziad. What I did, I said, okay, let's try with a simple balloon if I can. I tried a couple of times. You can appreciate how much resistance I had. Tried a couple of balloons, smaller ones, and it was not easy to go there. Remember that the heavy calcification in the CT angio in 2018. So I told myself, let's stop here. I mean, this is not going to kill the patient. We can put him on maximum medical therapy rather than fiddle around with this. And I was quite worried, you know, if I do more harm by having distal embolization if I continue. So I left this for medical therapy, and this is up for discussion, so I did not. Now, the lima, I knew that it caused a problem in 2008. I knew that, and I knew the distal runoff of the lima was not a wonderful one from the end articulum. So from the right radial, how do you approach the lima? This is Simmons catheters. The neurointerventionists love them. This is Simmons 1, this is 2 and 3. They come in 5 French and 6. And there's some of there are guides also, which are Simmons. I like them. Look at the curve. You can negotiate the arch of the aorta, trying to get into the left subclavian through that. Or you can use any of the abates, left or right. But, you know, I use Simmons first. I use Simmons. It got me there initially, but I could not maintain a good support. So I had to exchange to abates left. That got me a good support with an extra support Teflon wire, and I got in the position I needed to. And then I threaded over the wire. This wire I use always is a long double exchange, 280 centimeter. So I had a JR guide. I'll show it to you. Here is the JR guide. Look how nice it's sitting in the opening of the lima and how beautiful the image is. And you see that local focal type of lesion. It's there. I mean, it's very high grade. That's my target. And this is the distal part, which has the end articulum. You can appreciate it here over here. So the rest of the thing is just routine. This is the stent. I put it there without dilatation because I knew from the CT angio this part was not calcified. And, you know, the guide was sitting beautiful in the lima. I could even take images very easily with the dye. Inflated the stent. And look at the pictures again. You know, the guide is sitting there, the balloon is protecting the mouth of the lima so that I do not dissect. Good results with some distal disease, which is an older disease. And I always do this when I do limas, especially from the other side. I take a picture of the subclavian before the vertebral and the lima to make sure I did not do any harm. So what did I learn from this case? So that I jump to the other case quickly. That radial approach in most cases, you can do it for diagnostic CAS and primary PCI. Patients, they really love it. They ask for it, like my patient. Left radial approach, it depends on your preference, whether to stay on the left side of the patient or pull his arm to his tummy and do it while you are standing on the right side. I think CTA is a wonderful tool to evaluate the grafts and the distal runoff after the graft insertion. And in my case, you know, it's very unusual to have a proximal to a graft insertion culprit like the circuit which we had, but it happens obviously. And some culprits like the circ I had is not suited for PCI and might be best and safely treated medically, and that's what I did in this patient. Should I go to the next one immediately? No,
can we stop here, Abdul, next, because I have some questions from audience regarding that you have already a post-CABG with a post-treadmill. Why you do CT scan for CABG patient? Let's speak about CT scan in post-CABG patient in real life. For me, I do most probably, if it is not an emergency, I do CT for all patients because it's easier for me to go for non-STEMI patients or for patients with not with high troponin, for elective patients to know how to do it. Sometimes it takes a short time to do the PCI in such patient rather than searching for the grafts itself. I do the angiogram for the grafts, actually, repeat it, but actually do this. But the question of the audience, why you are doing CT in post-CABG patient with a positive stress test? Ziad, what's your opinion about CT in post-CABG in real life?
If you have a positive stress test, I mean, you can go straight to cath. I guess the audience was, you can go straight to cath. Now remember that CT also consumes dye. But if you did the CT for a different reason, without having the positive stress, so if you have symptom positive stress test, or if you have a positive stress test, even with symptoms, the next step, if you want to do anything, would be a cath. But let's let Hadi sort of give us his opinion on that.
Well, what happened, Ziad and Muhammad, this patient refused to have the left heart cath and the graft angiogram I recommended in 2018. So that's why I did the CT angio and layo of the coronary angiogram for this particular patient. But I would have, if he agreed, Now, in general, CT coronary angiogram, in general, if you have a patient, not this particular one, and you want to evaluate the graft, it's a beautiful tool because it shows the grafts beautiful. The distal runoffs, most of the distal runoffs usually are not that calcified, and you still can visualize them beautiful. It's not a great tool for looking at the native vessels which are grafted, because most of the times, Muhammad and Ziad, they are calcified, you don't see them clearly, and you cannot really judge them definitely. But for the graft and the runoff, it's a beautiful thing. And I'll tell you something also, where the value is. If you don't have the operative report of patients you are doing elective coronary angiogram for, not knowing how many grafts they have. So it's a beautiful guide for you before the CAT to know what you're looking for.
Hadi, there is a great review article in JACC 6 months ago or 4 months ago. And I have a presentation just last week. I summarized this with the Egyptian Society of Cardiology. I can send it to you. Regarding the arterial, the arterial and venous. They said that for the arterial, you have to look for the subclavian. If you have an angina, subclavian, usually there is stenosis, and look for this. And also for the lima, for the distal vessel, distal to the lima, it's better to do balloon rather than stenting. It's good for ballooning. It's not stenting anymore, except in very tight lung stenosis. They prefer ballooning, and they have a good result, a different study about this. What's your opinion about this two?
I think Ziad also remembers, and you remember, Muhammad, from I totally agree with this. Distal run-up vessels, the LAD after the lima, not at the insertion side. They respond nicely to simple balloon angioplasty. If you do a balloon angioplasty with a stent-like result for these, they usually do fine. But
I mean, it
really depends
on the lesion. If you have a 2.5 to 3.0 long lesion, you have to put a stent. Otherwise, the stenosis would be too high. Shall we go to the next case?
Okay. So I have to stop sharing first the ad so that I get the other one.
Before Hadi, there is Abdullah Shihab from Emirates to Ziad Ghazal to us that regarding the COVID presentation, that great as usual. All STEMI get PCR tests in Emirates, all get primary PCR except ARDS cases. This is the policy, not optional. Significant COVID cases were asymptomatic, but result came back positive. We all have PPE level 2 at least. Some hospitals have dedicated cath for COVID, but majority have negative pressure. As you can see, depending on the hospital, on the region, I think this should be the future of all cases we are going to do. Okay.
Very good comment.
Yeah. So my second case here, I titled, "How should I treat?" This is a patient who is 39, pretty young, smoker, No previous history of diabetes, atherosclerotic cardiovascular disease type of risks. He is a bit obese too. He came in with non-STEMI, and an echo showed an ejection fraction of 40 to 45%. And the echo more or less told me where the problem might be. Anteroseptal hypokinesis was there. The patient came in later in the evening, I remember, and he presented a bit late after the chest pain. So put him in the CCU, gave him the usual cocktail for non-STEMI, and with a plan to do the morning coronary angiogram. This is the EKG upon the presentation. You can appreciate some Q wave in lead 3 and AVF for our progression in the septal leads, but nothing to focal things for you rather than the echo. The echo was helpful for sure. So, radial again. This is the 6th French guide. I usually for STEMIs and non-STEMI, and that's open for discussion. My favorite guide is an Ikari guide. Most of the time, Ikari 3.56 French, inner diameter 0.071. And this Ikari, I can flip it between the right and the left easily. So I usually do, most of the cases, like 9 out of them, I use only one guide, no diagnostics. So this is the guide. The guide is sitting into the left vein. And look what the patient has, 39 years old, just a smoker, no other risk factors. Trifurcation lesion, 2 diagonals, a high-grade lesion in the second obtuse margin. You can appreciate that, I'm sure. And yes, this is, again, the PA cranial. Look how ugly the LAD is. It's a 111. There are 2 diagonals, and if you have very, very good eyes, you can see that the first diagonal here is come with an acute angle, relatively smaller runoff. So it's not the most important diagonal. This one is a huge one, this one, which has a very tight stenosis proximally involving its ostium. I'm sure you can appreciate that. The right coronary has an interesting anatomy, and you can see part of the right filling up from collaterals from the left here. Large vessel coming here, and then, you know, it curves this way where it's totally occluded, but there's a very large RV branch here. You appreciate that. So the continuation of the right is not that huge. Okay, so this patient at that particular time, 40-45% ejection fraction, I told, while he is on the table, maybe that was not fair, I told him that he needs CABG. So he started begging me that I don't want, I am too young for this, you know, the whole story. His wife came in and she was almost crying in the area, the waiting room, that they don't want any open heart lungs. But I thought that it's not a bad idea to have an open heart for this patient at all. What do you think, guys?
If it is a very high risk patient and the patient, I think the artery is closing, so you have to do something for this. They cannot wait for surgery except if you have an emergency.
Well, this is non-STEMI overnight, though, Muhammad. I mean, you know,
overnight, I think it's better because although this patient is diabetic.
No. He has no diabetes. No, he's just a smoker. 39, moderate obesity.
He's young with the syntax. I think it's intermediate syntax score. It's not a very high syntax score.
I agree.
And the most probable, I think the REMAS is easy. The problem just for the diagonal ED. So it's a true bifurcation, 111. I think you can do it at night, even staging. You can do only the LAD diagonal, and then
sure,
it can be next day or 3 days to the others, OM and right coronary artery.
Obviously, from the echo, the LAD territory is the culprit. It was anteroseptal hypokinesis. What do you think, Ziad? I think Ziad, we should offer the patient CABG for those patients.
Yes.
Just, you know.
I mean, this should not be done without at least mentioning the possibility of CABG to the patient. Whether you do it on the table or you take him off the table, it's okay. I mean, you know, after all, we don't have to have the heart team every time.
Totally agree.
In his room. So here you told him bypass, and then he said no, so you're going to go for angioplasty.
Exactly.
And here what we have, the OM2 is simple. the LAD diagonal is complicated. So why is it complicated? To wire the diagonal is going to be a bit of a challenge, because immediately after that 90% lesion, you have an acute angle which is going upwards. So the curve of your wire is going to be affected by that lesion. So, but I guess it's a bit challenging, but I guess it's doable. And in terms of what are you going to stent? The diagonal it's a bifurcating diagonal. The lower branch has also a tight lesion, which I would stent across. I would stent across the other smaller branch. And then, of course, this whole bifurcation of the LAD diagonal, how are we going to treat that? What do you think, Muhammad?
I think this is a classic case for DK crush or mini crush or K-lot technique, because the angle is less than 70. More or less, it is sizable diagonal. They have a 2 critical lesion. It's not for tap. It's not. You should stent this diagonal. The problem is stent diagonal first, or to pre-dilate and then stent LED and then recrossing. But I think it's a critical diagonal more than LED, so it's better to pre-dilate both and then stent diagonal, doing a DK crush technique, and ending by this kissing, double kissing.
So Hadi, what did you do? Tell us.
Okay, so
just for the sake of time, so that we can.
Yeah, sure. So he was already on aspirin, loaded him with ticagrelor, started thiopheban in the cath for the patient, just because I knew that this is most likely a clot-containing lesion. So thiopheban started, ticagrelor given, and aspirin is already given from the night before. So we discussed this. The technique I chose, mini crush, Muhammad. We can argue about this. So what I did, this is radial again, 3 wires, pre-dilated the second diagonal. I managed with the first diagonal, Ziad. It was a bit tough, but I was lucky in a way. I got in it. So I dilated that diagonal, stented it, crushed it with the balloon in the LAD, which was parking there. It is a mini crush. Put the stent in the LAD and dilated the LAD, and then I had a final kissing balloon, like what you suggested, guys.
Okay.
Is that decent enough, Ziad? You think that's
yes.
okay?
Yes, of course.
So now I was getting happy because things were going smooth. Well, not anymore.
So far you have a stent in the LAD, and what do you have in the diagonal?
Stent,
mini crush.
So I have a stent in the diagonal.
Okay,
I really crushed it with the LAD balloon. Then I put an LAD stent and did the final kissing.
Now you have a clot in the trifurcation of the left main.
Yeah, saddle-shaped clot, a huge one, sitting in the distal left main, extending into the circ and the LAD. And I'm sure you have, guys, good eyes. You can see that there's a clot sitting there in the stent of the LAD. If you
what about the ACT usually in your cath lab? Is it routine or?
Yes, I do. But I wasn't checking it at that time, but I checked it immediately. It was 350. It was 350.
So now what do you do here? The most impressive one is around the left main. The circ in the one in the LAD looks a little bit less impressive. Can you suck it out?
That's a very good question. It crossed my mind, Ziad. Should I do aspiration embolectomy for this? But you know what I thought at that time, that I have to do 2 runs because it's extending into the circ. So if I go into the LAD, I have also to suck the part in the LAD stand, then come back to the one in the left main. And if I was successful in this, that would not most likely be enough. I have to do another run through the circ. That's what it caused my mind.
What did you do?
Well, what's really funny, because the ACT was good, and the patient was already having thiopheban on board. And that's good for our young physicians watching us. Immediately when I saw the clot, I pulled the wire from the diagonal, which was stented here, you know, and has a good flow still. And I immediately put it in the circ because I didn't want to have to lose the patient in the cath lab. You know, you have to secure something. So I pulled it out and I put it in the circ. And, you know, with the immediate injection afterwards,
it was gone.
Look at what it moved on, got part of it in the ostial diagonal, most of it here in the LAD stand. So I started, you know, the first thing which we should do is just I got a balloon in the area of the LAD stand. It worked, but I'm sure it worked on the expense of getting more clotting downstream. Look at this here. It was a complete cut-off. I gave him a lot of adenosine, nitroglycerin, used balloons for massaging the artery. Can appreciate that.
So you went straight with the balloon, Hadi?
Yes. No, I mean, why did I went with the balloon immediately at that time, Ziad? You could argue of doing the aspiration at that time.
Yeah, I think
because it was occluding the LAD and the ostial diagonal. His blood pressure was going down, ST elevation was sky high. So I had to do something quick. So that's what I did. And I massaged the whole artery, but I could not really regain the distal 1/3 at all. And you know, before the 2 pictures before that, you could say that he had no reflow, of course, but there wasn't a good reason for it. So in spite of all the pharmacology and the thiopheban and the ACT being high, I did not want to leave the cath lab losing this here. I really felt bad. So what I did, first, I want to make sure that I make easier for me to rewire the diagonal in case I lose it. So I did the pot quickly in seconds and the proximal LAD stand with a big balloon, non-NC balloon, short one. And what I did, I put a microcatheter, Ziad and Muhammad, down where the area over there is. And look at this beautiful thing. When you inject in the microcatheter, the dye doesn't go downwards because it's occluded. It went backwards. You can appreciate that, right?
Yeah.
Over here. So I knew where the problem is. So what I did through this microcatheter, I injected tons of adenosine. It did not work well. And then I gave him a touch of adrenaline, just a very low dose. You can appreciate the tachycardia. And I massaged the area multiple times. And the patient started settling down. You can appreciate the first diagonal with the acute angle that the flow was not at its best. But I was not really worried about it because you know, the second diagonal is big enough to not worry about it. So with all the manipulation, the pharmacology, the microcatheter, I think I got it back. And the perfusion was good. TIMI3 flow, MBG is very decent. There's some irregularities here, but I thought overnight thiopheban, DABT, etc. will take care of it. You know, some people would ask, what should you do with the OM2 and the RCA? Obviously, I didn't do nothing at that time. So
you didn't want to go back to that first diagonal, which is jailed, correct?
In terms of stenting, yes. Yes, it's just at the edge of the stent, Ziad.
Yeah, but
it's not a large diagonal, Ziad.
It's not, no.
It's okay. It starts like a big diameter, but it's really very little at the end.
Eddie, we have some questions. You have to. Should have quick answers.
Yes.
Number one, few are recommending CABG, not PCI. As we can see, that we should have a heart team. This could be preferable.
But the patient said he does not want to. He already talked to him.
I talked to the surgeon. I talked to the surgeon in the institution. He was available and he was ready to have the surgery done. But the patient adamantly and his wife said no.
The second question here. Second question. The second question regarding why we don't give intracoronary thrombolytic therapy in such case.
I don't believe it works really. I mean, intracoronary thrombolytic therapies, they really don't work. And you know, if you use if you use it inside the artery, from the old literature, I'm not sure I'm enthusiastic about it. What do you think, Ziad? I mean, I'm not.
No, I would consider it. Yeah, I mean, 2 milligrams TPA given very slowly. I see if the patient is stable. You know, I mean, it's classic. It may help, it may not help, but I think I would give it. I would consider it. Yeah. Any other question?
I can. For me, I will do aspiration first, and sometimes and giving all measures of nori flow to prevent nori flow. The third that I can give, and sometimes I give intracoronary tirofiban. But I don't give a thrombolytic.
Sure, but the problem, my friends, that if intracoronary G2B3A is, you know, the meta-analysis did not show that a great benefit out of it. So
I think this
I don't know.
He's already on the IV thyro. I mean, very good choice that you started with IV tirofiban.
Yes,
okay.
I did immediately.
Wonderful. Thank you so much,
Thank you.
Hadi. Mohammed, do you want to go to your case?
Yes, please.
You stopped sharing, Hadi, صح?
Yeah, I did.
Stop sharing. Hadi?
I stopped sharing, didn't I?
Okay.
Yeah, I did.
Did you stop sharing?
Yeah.
Okay.
أنت بلش تحت share screen, محمد.
Okay.
Share screen وبين the presentation.
I'm sharing the presentation. Yes, now. Okay. Did you see it? Okay.
Yes.
Okay. This.
If you want to go to full screen now. Yes. Excellent.
Yes. Thank you, Ziad and Hadi. Two wonderful cases. This is one of I choose one of the difficult cases in my life. I call it, oh my God, it was incredible story. This is a female, 54 years, Clark, 4 children with diabetic, mild hypertension, complaining of angina class 2 to 3, rest and exercise, sometimes resting ECG T-wave inversion, transthoracic echo, normal wall motion, ejection fraction 56%, failure of medical treatment, so they asked for elective coronary angiogram. This is the first injection, as you know, that's just a diagnostic catheter, and I found this. So I said,
all she was having was exertional and rest angina.
Yes.
She was stable.
This is first injection. I said, oh my God. And the patient developed bradycardia hypotension. What do you think, Ziad and Hadi, for this? What happened to the patient?
So what's the EKG? Is this acute? This must be acute, right?
No, it's only T-wave inversion. Nothing.
So there must be collateral then. It looks fresh. It looks acute. Yeah, the EKG only T-wave inversion.
T-wave inversion.
Okay.
But it's an elective case, not an emergency. I sent it to cath we didn't do CT.
And you said the EF was good.
Ejection fraction 68%.
So it must be fully collateralized. So we have to see the rest of the pictures.
Okay, first injection. Oh my, patient developed bradycardia, severe hypotension, 75, 50. So I put the possibility.
So now, okay, exactly. So now that happened on the table. So that's basically so that's not the collateral situation.
No.
Something that happened on the table.
I have 3 possibilities we can discuss together and with the audience: air embolism, or dislodgement thrombus, or left middle section, or others possibility.
The air embolism, Muhammad, you know, there's no evidence of that, I guess. I mean, you know, it's just, it can happen, of course, but you have to inject really a large air embolus to occlude the arterial lady.
No, but I have cases like this actually in my life. I think all of you, this is sometimes there is, when changing for me, I'm not doing hand injection, usually doing with a pump. Sometimes the connections happening, air embolism, so I know how to, this is but the patient usually in all these cases develop, but the problem that I'm not sure. So first possibility for me at an air embolism, I couldn't imagine, is or a thrombus, but I couldn't see left middle dissection. Ziad, what do you think?
I mean, I think what you have on the slide, it doesn't look like a dissection because I don't see a dissection flap. It could be air embolism. and it could be thrombus. I can't think of anything else right now, but most likely
massive spasm can happen. You know, it can happen.
Both arteries.
It can, sure, it can. It's
Okay.
massive spasm. It can happen.
Is the fourth possibility.
Yeah,
So,
and for massive spasm, embolism, clot, dissection.
What I did, I put 3 wires, LAD, ramus, and then patient is now arrested. This is patient, and as you see, patient is going to be arrested, and then cardiac massage. And while the cardiac massage, asked anesthesia to come use the nearby room, usually in the catheters in our ICC. We have an anesthesiologist, even in our university, but it's easier for the private to have anesthesiologists, ventilation, cardiac massage, and the wires inside. And then we put a balloon, 2 millimeter for CX dilatation. Then when I'm after the balloon, there's a second arrest again. And the balloon went to ramus. And during this cardiac massage, it's difficult usually to look while doing massage in and out to have looking for the arteries. After that, this balloon dilatation, LAD and ramus. So what do you need more now? Any question? But we didn't see nothing in the arteries. Maybe some spasm in the circumflex, nothing LAD and ramus. What do you need? I think
look at the circ, Muhammad. You know the circ. Look at that. The mid area, the distal is this. It has a big spasm issue too. Huh?
Deep picture. What to do now? Iraq, Ziad, what do you think?
Yeah, spasm is still a possibility. Air embolus, sometimes you don't see it, but spasm is more likely to be relieved. It's quicker than air embolus. Air embolus shutting down all the LADs along quite a bit of a longer time. Unfortunately, the pressure is still low. So otherwise, nitroglycerin would be the first thing I would give. And you're restoring almost a TIMI-3 flow. There are already several spastic lesions, it looks like.
Exactly.
So
I mean, look at the circ, Ziad and Muhammad. I mean,
here we can see here.
There's spasm in the circ here.
The ramus here, the ramus, the C. So I think this at that time it's spasm. So I move the wire out. Blood pressure is 80, 60, and the heart rate is 140. Give nitroglycerin, slow dose, and then checking the right coronary artery. It's a small non-dominant right coronary artery. Then I come back to the left system. What do you think this? As you can see, slow flow again, and small circumflex with TIMI 0 to 1, and something here in the
skinny. I mean, I think Hadi is correct. This is all looking like spasm.
Spasm.
Yeah. What's the blood pressure now?
Is 80/60.
Yeah.
Yeah, the way it's behaving, Ziad, the way it's behaving, you know, it's not an embolus, it's not a clot. Yeah. Dissection, as Ziad said, there's no flap showing. I would say this is a massive spasm, most likely.
I would still give 50 nitro, even though the blood pressure is low, just a low dose. If it starts opening up, then I have secured the diagnosis. Okay. And notice in that first ramus, what we thought was a spasm is most likely a kink, and it was tighter on the previous. So I think the diagnosis of spasm is more likely.
What are your thoughts, Muhammad and Ziad, about giving, in those cases, even with low blood pressure, IC nitro? You think nitroglycerin in somebody, if he has a blood pressure of 80 or 70 with massive spasm, what do you think of that in terms of, would it really bottom down the blood pressure? Yeah.
I would still give 50. 50 is a small dose. You're giving it.
I would, Ziad.
Because you need to count. So what did you do, Muhammad?
There's a possibility here from the audience. I looked for the chatting. There's a SCAD. What about SCAD?
It doesn't look like it. The way the arteries are opening and reclosing, it's not SCAD.
It's not SCAD.
I agree.
Yeah. I mean, just because of the morphology. I mean, you know, it's open. It's
patient, you know, when I do angiogram for just 2 minutes, the patient is now arresting again. So I call again for wires rapidly with balloons, but not time in the LED, balloon dilatation LED. And this is a third time arrest while the balloon is inside. So relief for a while, but I don't know what's next. What's next?
Well, I mean, what's happening here, Mohammed?
Look,
Good flow.
yeah,
Good flow
go ahead.
now.
I'm sorry. It looks like the way it's behaving, the vessels, they are actually clamping on you in a way. I think it's a massive spasm still.
Yeah, yeah. The diagnosis is made now by this view exactly, Hadi, like you're saying. I mean, you saw the circ. You have 3 morphologies of the circ, or 4, one closed, one spasm in different direction, in different areas, one open like this one. So this is all a spasm.
So I remove that, then check again, check and wait. And then when checking and wait, there is a spider view. Then I look with my colleagues in the operating room. We can see something here but we are not sure of here in the spider view. Do you see anything here in this view?
It's hard to appreciate it.
Hard to appreciate. Actually, I didn't use IVAS or OCT, but we don't have OCT, but we have an IVAS. But actually, with this situation, we are afraid to bring the IVAS catheter. Even the wire, something happens. So I'm afraid to have an IVAS. So we said that it's a query dissection, but we are not sure. So we said that, okay, could be a dissecting flap. Then we remove the wire. We didn't do anything. A recheck. But what is this again? We have no wires. We have something here. When you remove the wire, we can look here to the proximal part of LED. Something happened. How do you decide? Then these are again, while we are looking to the angiogram, the patient developed a 4th arrest. Then rewire again. This is rewiring for the 4th time. So we decided that time, okay, we are not looking for the art. You have to do something for the proximal LED. We have to do stenting with the left main LED. While doing arrest, we have put a drug-eluting stent from the left main to LED, no way. And then full deployment, but still the patient has bradycardia and hypotension. And again, even after the stenting, the patient had the 5th arrest, and be cool again, because this is the 5th arrest. Nothing happened. So what to do now? We put an intra-aortic balloon pump and remove the wire and relax. And we call it safe landing. Finally, nothing happened to the patient. Blood pressure again, heart rate is 125. So the patient remained in the hospital for 4 days. We removed the intra-aortic balloon and ventilation within 2 days. Is adapt, statin, beta blocker, insulin therapy. 2 months after, developed chest pain, normal ECG, normal cardiac enzyme, normal echo. We sent the patient, refused to do angiogram, sent the patient for multi-slide CT. As we can see, the left main stent is okay. Nothing in the circumflex, nothing in the LED stents, even the bifurcation. There is a normal right coronary. There is an occluded ramus here, as we can see. Finally, 1 month after this, the patient developed after full medical treatment, patient developed unstable angina, but they went to other hospitals. They refused to come to me. She came to one of our colleagues because she was afraid. She was ventilated in our hospital. So they went to other hospitals. That's why the bad quality, sorry for this angiogram, patent left main LED. But we can see here, there is an ostial circumflex artery. We didn't finish for the 3 months.
You have a stent across it, correct?
Yeah, stent left main, but there is nothing in the circumflex. We didn't do kissing. We didn't.
Yeah. But I mean, it's a pinched, it's an osteal lead because of the stent.
Yes, because of the stents. But this is after 3 months. As you remember, in the CT was normal. LO cranial is normal. Lateral view is okay. And spider view showing again ostial circumflex tight lesion. The same non-dominant right coronary artery. LV angiogram, ejection fraction 65%. The main site of restenosis after left main stenting. This is not diffuse restenosis. If you have a diffuse restenosis, so you can consider CABG or PCI, but actually CABG or drug-coated balloon. Isolated left circumflex restenosis. If the routine left main restenosis after LCX, if they have a small LCX medical treatment, If you have a large CX, we can consider CABG. But what is your decision, Ziad and Hadi, and the audience for the left circumflex?
If you believe her unstable angina is coming from it. Now, let me tell you, when you see something like this, it has happened at the time when you put the stent. It usually doesn't happen later. You pinch it at that time. So, is it something that she developed the symptoms later? But if you're sure it is part of it, you said CABG. Did you send her to CABG?
Not me. She didn't came to me. I heard from her colleagues after CABG. I saw the patient after CABG. That's why her doctor sent her, because he asked her for PCI. She refused. And so he went her for CABG. I saw the patient 2-3 months after. The patient was stable and nothing happened to the patients. I don't know what happened to me. For me, I will not send for patient for CABG. I will put wires in the CX and do kissing again. And maybe
most of the people in the audience, we have 4 messages: DEB for circumflex or stent PCI circumflex. And I think we would do the same.
I would. Ziad, I would agree with the audience. I think for this particular patient, if we believed it was a massive spasm from the beginning, now having an ostial circ with an LAD to the left main stent, I don't think this is I'm not sure how to put it. This is not a great indication for open heart surgery. Because
and it's not a big circumflex anyway, and it's
exactly.
It's doable by PCI. And I like the idea of drug-eluting balloon.
Yes.
So the patient did well finally, Muhammad?
Yes, did well, but for this case, yes, patient went well, but this is one of the cases. Sometimes even I put a stent, even the patient develops circumflex lesion after 3 months. I don't know the cause. It could be a possibilities, either the spasm or dissections or thrombi. I don't know until now, but actually this is a spasm, as both of you said that. But something like a query, maybe something like the section for the caster.
So how would you treat her long term with medications? What would you avoid? What would you treat her with?
It's
probably avoid beta blocker.
For this case,
for the spasm part, he means.
Yes, for DAPT, for calcium channel blockers, sometimes I give some nitrates and high intensity statin. That's why I'm giving this.
Yes, high intensity statins, calcium blockers, nitro patch maybe, but it will give her a headache. And would you avoid beta blockade here?
I would.
Yes.
I would.
Yes.
Yeah.
Yes.
Yeah. Okay. Shall we go to the last case?
Yeah, this is the last slide regarding learn and teach for this case. No simple caster. I remember our boss, Spencer King, and when I come to the Emory, he was there. He said to me, Muhammad, there is no simple cath. You should respect every patient. There's no simple PCR, there is no simple cath. Because sometimes you have said simple, it's not. But don't be panic and stay calm and cool, confident. You are the cath lab leaders. But teamwork is mandatory. Fight for the life of your patient, and God will help you when you do your best.
Very good. Okay, thank you. Thank you.
Thank
you can stop sharing so that I share the last presentation.
I will stop sharing.
Just for the sake of time.
Yes.
Okay, so I'm going to take you through the last presentation, which I can't find anymore. Let me see. Interesting. Okay. Let me just see. Oh, okay. Do you see it? No, not yet.
Not yet, says yeah.
Yeah. Let me close one of them. One of them is distracting the other.
Oh.
Okay.
while you are
Yeah,
preparing
bear with me.
the territories also from Dr. Muhammad Al-Territories also from Dr. Muhammad Al-Jabri, who is insisting that this case is SCAD. I agree about it could be a SCAD because it could be some part of SCAD and with severe spells with Dr. Muhammad.
Yes,
Yes,
SCAD usually progresses. It doesn't get better and worse by itself. I mean, I don't know. But anyway, so here's a case that I want to share with you. This is a case from 2 years ago. 2 years ago, because I had follow-up, so I needed to kind of, I thought it would be interesting. So this is a 35-year-old male patient who works at our hospital. He's previously healthy, risk factors, believe it or not, engages in bodybuilding exercises, does not smoke, negative family history, no known risk factors for coronary artery disease. Experienced sudden onset severe dyspnea, chest discomfort, presented to the emergency department in moderate respiratory distress, less than 1 hour from onset of symptoms. Blood pressure and vitals were fine. Heart rate was 96. So here we have his EKG. You want to comment on it, Muhammad?
Mute my
Hello?
video.
Yeah.
Yes, it's a raising ST segment, huge 5 meter in the lead one, AVL, and from V2 up to V6 or to up
Yeah,
to
so it's a huge territory, STEMI. He denies any history of illicit drugs. We always have to ask that when you see a young patient with no risk factors coming with STEMI. So he denies any of that. We loaded him with aspirin, ticagrelor, heparin. The bedside echo, while we were just getting him ready to go up to the cath lab, EF was 25%. This is a quick echo. Usually you don't need to waste any time with such things, except the echo machine is very handy. Now, in terms of cardiac catheterization, Muhammad, would you do him radial or femoral?
Depending on the cases. If you are in a hurry, in cases, usually do a radial in 70 to 80% of the patients nowadays.
And
But 2 years ago,
like,
yes, for STEMI patient. For STEMI patient.
Yeah. So that's, yeah. So most of us do that. And in fact, when you look at the guidelines, ESC guidelines, radial access is a class 1A indication, even with STEMI. Now, remember, when you have such a big STEMI, huge, with that much loss of ejection fraction, it's not wrong to go femoral because things may go south, you know, with the large 7 French catheter. But we went radial. This is the first picture of the right coronary artery, and look normal this artery is in this young guy. And this is the picture of the left coronary artery. Okay, so you see it's the left main, and you see what appears like an ostial LAD and a small circumflex. Okay, so we go after that LAD. Well, actually, before that, as we were taking the picture, he started developing worsening dyspnea. Bibasal arousal, oxygen saturation dropped to 84%. So he goes into the pulmonary edema. We start him on BiPAP. Blood pressure drops to 85/65, becomes a bit more tachycardic. We give him Lasix and pyrofiban drip was started. And then he has 1 episode of sustained ventricular tachycardia, which was successfully cardioverted. So now the question for you guys and for the audience, do you call a surgeon? We have him on 2B3A inhibitor already. Would you just put an intra-aortic balloon pump? I'm not sure we have ECMO in our lab, but we didn't feel it was necessary yet. And Muhammad or Hadi, if you can check the audience questions, I would be interested to know.
Okay.
Would anybody just wait on a surgeon to come and convince the surgeon to take the patient, or just go ahead and start immediately with the work?
زياد هو from Dr. Muhammad Japouri, intra-aortic and PCR, from Dr. Khalid Lyon Impella, Dr. Habib Tarif, intra-aortic balloon and surgery. So there is three answers here. Completely.
But I think, yeah, but I think, Muhammad, you know, the bottom line about this is a lot of us would know that balloon pump data is not that encouraging. The only issue, not all the hospitals have ECMO, not all of us have Impella, and not all of us have access to a quick tandem heart. That's where the problem comes up. But if I do have Impella, I will put it in. If I have access to tandem heart, I will do it. Intra-aortic balloon pump, unfortunately, becomes the only thing available to a lot of the audience, I'm sure, though we don't have good data of outcome for it. So.
The best would be Impella. If we don't have Impella in our lab, we don't have it in the country, but Impella is so quick to use. You can use 0.5 liter per minute or the 5 liter per minute much quicker than any of the others listed here. Certainly, ECMO tandem heart is a lot more time to.
We have to answer two parts of your questions.
Yes.
In STEMI cases, don't call a surgeon for a STEMI except if you have a mechanical complications. Otherwise, even if they have a left main, you have to open the artery because there is no time to call for a surgeon. Regarding the use intra-aortic or Impella or something like this, according to the culprit shock, no need for intra-aortic balloon to be used in this field. Just to do an open. When you open the artery, blood pressure is raised down. Raised up.
Yes. So regarding the surgeon, I would say I would recommend to call a surgeon just to have the surgeon on standby and obviously start the work. But I think calling the surgeon to be on standby in this case is just because the guy is young and things can get, you know, the whole left main may close. So let me continue with the case just because of the sake of time. Yeah. So we wire it, we start getting some flow. This looks like an LAD. And then, so now that's nicely opened. So what do you think this vessel is? It looks like an LAD, Muhammad, correct?
Yes, yes.
Okay.
And it looks like an LAD. Yeah, you know, I'm sorry, Ziad, it looks like an LAD, but it doesn't have a lot of septals coming out. So.
Exactly. Exactly. So we took another view, and it's an LAD. It's a ramus or a diagonal. Okay. So we very carefully fished for the LAD. Very difficult to find because there was no stump, but as we were working, you know, we started seeing that stump as you see up here. We wired it and ballooned it. Okay, so now we have LAD, wire in the circ, wire in the LAD, and wire in this diagonal or ramus artery in the middle. Okay, we ballooned it with bigger balloon, and then we ballooned the ramus again, or diagonal, and that's what we have. So where would we go from here?
I think probably something which comes up to the mind now. Beautiful job so far, Ziad. This is a young patient, athlete. There are two things unusual about the presentation. When he came early on and already has a short ventricle, the ventricle is 25% ejection fraction, which is really very unusual, Ziad. I'm sure you agree. It's not common. And the other thing, look at the arteries. They look crispy clean everywhere. And
except for that distal left main. I mean, the distal left main.
Yeah, like but that's what I'm leading to, Ziad. This is a patient where type 2A spontaneous coronary artery dissection might come in place. Because clean coronaries, two vessels, including the LAD, it's okay. It can be involved in spontaneous dissection. You don't have to have a flap or something, or this is enough to have it in mind as a diagnosis, I think. So I would say this might be a SCAT. It can.
But you would see a flap. I mean, I think I would disagree there because I think you would see a flap. I mean,
but see, it depends, Ziad. It depends, Ziad. When Jacqueline saw the one who had this beautiful review of the whole SCAT issues from Canada, The type 1 SCAD, which you see flap, actually is the least common there. It's hardly in 30% of SCADs. The most common is the type 2. Type 2 is like this one. There's type 2A and type 2B. This is type 2A, where you have just about 20 millimeter plus minus, including the vessels. It can involve more than one vessel for sure. So I don't know.
It's the length of the dissection that has to do with this classification. I mean, some of them are small, but
sure.
you okay. So how would you tackle that, Muhammad?
But still, we have to answer to برضو في two questions from the audience. One of them is insisting to have a CABG. If you have an TIMI3 flu and you have triple lesions or 111 with some impingement of the circumflex, I will answer this. I will never send CABG to eat during a STEMI patient except the mechanical commission. I'm still convincing about this. The mortality rate is very high, morbidity rate is very high in even the best centers. So this
remember, Muhammad, this patient ejection fraction is 25%.
We don't have the vitamin echo. Could be stunning, be acute stunning.
No, I'm agreeing with you that I don't think Ziad, there will be any surgeon, which I know personally.
This is
take him to the OR immediately.
Question number 2 for me, I will wire the 3 LAD, Ramus, and I'm consisting to make it the best is to left main LAD, and then kissing for left main Ramus, then left main.
You would do a stent left main LAD.
Yes, I try to finish with 1 stent. I will try. If not, you can make a stent of the Ramus, not the CX.
And notice how the slow flow is in the LAD. You see, it doesn't. So anyway, so we did balloon into the left main LAD, and we stented it with a 3.5 by 18 millimeter stent. Now what we have, so notice how you have a nice stent sitting there, and you have this wire in that diagonal which is closed, and you have the circ which is pinched. So we did something bad, and we did open the circ, the LAD nicely, but the ramus or diagonal is closed, and the circ is pinched, and the flow is a little bit slow. Okay, so what would you do now?
I make a pot again, and then open the circumflex, and then open just ballooning and see what's going. And then if I don't use, for practical speaking, I don't use IVAS during the acute setting of STEMI.
No, there is no need now. Now we have things, so that's your pot. And then this is where we have to rescue the rest of the vessels.
Ramus.
Okay. So regarding, so we decided first to go to go ahead and dilate the circ which is tight, because if we balloon into the ramus, most likely the circ would close because they're all at this bifurcation. So we dilated there, and then we put a stent. So this may not show you the stent very well, but this is a stent in the ostium of the circumflex, and this is a balloon into the diagonal, ramus diagonal. Okay. And we did sort of a tap technique. So again, this is the proximal edge of the stent in the circ. We did a tap technique, and then we moved the balloon back. That's into the ramus and the circumflex, as you see here. And then we did circ and LAD kissing, circ and LAD kissing. And that's what we got. Okay, nicely opened into the circ with that stent, and nicely open. So that's a tap technique, LAD and circ. The ramus is just a balloon result. This is how it looks.
You know,
flow is better.
Ziad, sometimes I have cases like this. I make balloon LAD ramus, balloon ramus, and circumflex in order to make kissing. I didn't do three balloons at the same time, but make it. But
We don't want to do, of course, we don't want to do 3 balloons
Only 2 balloons.
at the same time.
Yes.
2. So we did 2, circ LED and with circ Remus. Okay,
Yeah.
as I showed you.
I think the big question, Ziad, which a lot of audience might have in mind, how many would have stented the ostial circuit or just do simple balloon with kissing into the LED? And
the ostial circ we stented. The ostial circ is stented here.
Yeah, but I mean, how many would have done a stent rather just a balloon trying to retrieve it back? I don't know.
Okay, yeah, that's a good question. That's a good question. But anyway, so that's how we ended up.
Great.
Fairly good result. Notice there is some disease in the mid-LAD, so it's not a very benign LAD, or it may be looking this way because of
spasm. Yeah.
Maybe because of spasm.
Yeah.
So the patient left the lab in a good condition. You still see some very mild slowing of the LAD flow. Okay. And he was fine. He left the hospital a few days later with an EF that picked up about a month later to about 35%. 1 year later, he's doing well. His EF is 35 to 40%. He's apprehensive. He's so scared. Why did this happen to him? He's so healthy. He's athletic. And he's apprehensive because he wants to get married. And he's worried, can he really get married? He doesn't like his beta blocker because he wants to get married. And he's asking how much exercise is he allowed to do? What would you tell him? How much exercise is he allowed to do?
Well, ejection fraction is 40% now. I think it's we can trick by walking first, and then we do a treadmill after. Is this 1 year later?
1 year.
Yeah.
There is this left main stents and all that. Yeah, Hadi?
I think at 1 year out of left main circ, beautiful job which you did, Ziad, in improving ejection fraction. Of course, if he is in one of those countries which they have good rehab, he would have been rehabbed nicely. But we don't have rehab, but I think I agree with Muhammad. Yeah, you do have, I don't, but I think I agree with Muhammad. I think I would just exercise, condition him, put him on the treadmill, make sure he's okay, and just let him do.
And how long would you keep Taika for? 3 years or more than 3 years? I mean, a young guy like him, stents in the left main and STEMI, I would keep him at least 3 years.
And at least 36 months, according to the guideline.
2 years,
sure.
And how would you follow him up? Would you ever cath him again? Would you do a functional stress test, or you continue with optimal medical therapy and symptoms?
Definitely no routine cath. Functional stress test maybe for symptoms, which are not that typical. But I think optimal medical therapy and just strict follow-up will be my choice.
Strict follow-up. And he's always, every time he comes back to my clinic, he wants to have an echo. And I tell him, no, your echo, we just did it last month, we can't repeat it. But anyway, 2 years later, so 2 years from the from the STEMI episode, which is actually, this is last month, 2 years later, still asymptomatic and actually fairly active, and he finally got married, but the repeat echo unfortunately showed a significant drop in his EF to 25%. And we did a nuclear stress test. EF is 25, large scar, anterolateral scar, and there is no ischemia, so there is no point in cathing him. Why did he progress? Why is this negative remodeling? We see that sometimes. So I sent him to our heart failure specialist, Dr. Skouri. He's on Entresto now and other medications. And he's up to 200 milligrams twice a day, believe it or not. And he's doing well. So we'll repeat the echo. And if it doesn't get to the range of, close to 35%, he will get himself a internal defibrillator.
For sure.
But did you advise him to do an angiogram or do vitamin stress?
No, because there is no ischemia. No, because by the nuclear test there is no viability.
It's a scar, Muhammad. So I think, yeah, it's a scar.
As usually, I don't believe in 100% in nuclear itself. Usually, you both by a cardiac MRI, something like that, or the vitamin echo rather than nuclear money for ischemia, but not for viability. And scar will amount this is strange enough to change from 35 to 25. I don't know if there is an ischemia or not. Does his ECG change? Look to the questions from the attendee. Does his ECG show left bundle or narrow complex?
No.
No.
No, it's about 0.11, so it's not.
Oh.
It's not.
I think they're leading to CRTD need, I guess.
Yes, otherwise it would be CRTD. Yes.
Is it because sometimes there's a question here? Do you suggest that this patient develop left main instant stenosis, which is silent for this patient? That's why his patient ejection fraction now 25. What do you think?
I mean, we go back to I mean, everything is possible. We go back to the possibility of ischemia. Should we really cath him again? You know, should we, like Muhammad is saying, do a dobutamine, low-level stress test to see if he can recover? But really, because of the large area of scar, we were convinced that this is not necessary, but it's not wrong to do it because he's a young guy. Sure. And we'll see if he doesn't improve with the medications. You know, we'll keep thinking about it.
Do you have functional MR? Do you have functional MRs? Yeah, you do.
Yes, dobutamine MR. We don't use dobutamine MR much. I mean, you know, we do plenty of cardiac MRIs, but we could do that. That's a good idea. Or we could do a dobutamine, or just leave him and rely on the test of the nuclear test, you know, that showed us.
When do you decide to do a multi-slice CT following your stent deployment for your patient? Are you advised to do this 1 year, 2 years, or nothing except?
No, we don't do it routinely.
Routinely. In such case, because suggestion here from Dr. Isam Mahfouz to do a CTA, or these are from the audience, some of them medical therapy ICD, some saying that we can do a coronary angiogram, some saying CTA. So we don't have the proper answer because you don't have...
CTA is not a bad idea, but it's really hard to read instant restenosis in CT, correct, Hadi?
I agree. It's not easy. What was the size of the stent you put in, Ziad? LAD
took it up to 4.0.
Yeah, this... Because you know the good size, the good size of the stent might be forgiving actually to get a CT. You still can't see in the good CT machines and larger stents, metal stents, Ziad. You might get it, but it's just another alternative to doing coronary angiogram.
Ziad, do you think that part of the suggestion, this is the case of a SCAD, which develop another injury to the artery with producing silent ischemia in such young guy, or we don't have evidence for this because we have speculations of 2 cases or 3 cases of SCAD now. So what do you think? Can you explain to the audience?
I really don't think the appearance is a SCAD appearance. I really don't think so.
Okay. I think, thank you very much, Ziad. Thank you very much for this wonderful case.
Thank you very much.
I think we have to finish now. I'd like to thank Ziad for his lecture about the COVID reintroduction of the procedures now, because we are in the era beyond the COVID. This terminology comes from Hadi. He said that beyond the COVID. Thank you, Hadi. And thank you, Hadi, for a wonderful 2 cases. And I'd like to thank Abbott for Dr. Hassan Hammoud and all his group, Maria, and also Dr. Amr Ali, Dr. Ziad, Ahmed Yosfi from ICOM for preparing this wonderful, and Reem for preparing such wonderful webinar. وكل سنة وانتم طيبين ورمضان كريم ونشوفكم على خير و have a nice day and good suhoor.
Thank you all. Thank you all. Thank you.
Thank you. Thank you.
Bye-bye.